Assalamu alaikum friends. Today I am going to discuss question number 7 of Katherine Anderson mrcog part 1. Content of this videos are anal canal, obstetric anal sphincter injury, the obstetric anal sphincter injury care bundle. Question number 7 is related to anal canal. We'll discuss this at the end of the video. Now, anal canal, it is the terminal part of the gastrointestinal tract that conveys material from the rectum to the anus. It is typically around 3 to 4 cm in length. Embryologically, anal canal has two different origins. The superior two-thirds of the anal canal derives from the hindgut endoderm and are lined by simple columnar epithelial cells. The inferior one-third of the anal canal derives from the ectodermal proctodium and is lined by stratified squamous epithelium. The junction that delineates these two epithelia is called the pectinate line or the dentate line. Now in this diagram, the pink color shows mesoderm and the yellow color shows endoderm. Now in the first picture, which is represented by A, you can see allantois. Allantois is basically outpouching of yolk sac, which connects the urinary bladder to the yolk sac, and it used to eliminate waste products. During development, allantois, it's proximal and it's developed into urogenital sinus and distal and forms urachus, and after birth urachus forms median umbilical ligament. Then there is a proctodium, which is posterior ectodermal part of the digestive tract formed in the embryo by invagination of the outer body wall. Then you can see gut and urorectal septum, and then there is cloaca, which is basically short common channel for rectum, vagina and urethra. And then you can see cloacal membrane. Although cloaca is lined by endoderm, but when it directs come in contact with proctodium, which is ectodermal, then this structure which has no mesoderm in between is called cloacal membrane. In second picture, you can see that development of the reproductive system, and urorectal septum has divided the GIT and the urinary system. And in the third picture, you can see that urinary bladder is formed and the rectum is formed. They are totally separated, and cloacal membrane is divided into anal membrane and the urogenital membrane. Now this is the diagrammatic presentation of cloaca, which is short common channel for rectum with the urethra and vagina. Now the structure. The anal canal serves as a channel connecting the rectum to the end of the gastrointestinal system, the anus. It is located within the anal triangle of the perineum and in between the fat-filled and wedge-shaped ischioanal or ischiorectal fossae that accommodate its expansion for the passage of fecal material. Here I have encircled the position of ischioanal fossae. You can see they are present on both sides of the anal canal, and it helps in distension of the anal canal when it is filled with fecal material. Now the transition from the rectum to the anus can be identified by the anorectal junction or anorectal ring, which appears as a band in the gastrointestinal tract and is supported by the puborectalis muscular sling. Here you can see I have encircled the levator ani and puborectalis part. Here you can see that the puborectalis forms a sling around the anorectal junction, and it's blend with internal anal sphincter and the external anal sphincter's fibers. Anorectal junction is also the site where muscular fibers of the two sphincters blend superiorly with those of the puborectalis muscle, as I have already told you. In this picture, you can easily see that the muscle fibers of internal anal sphincter and the external anal sphincter, they blend with the puborectalis, which is part of levator ani muscle. Now the two functionally and anatomically distinct sphincters surrounding the anal canal are internal anal sphincter and the external anal sphincter. Both internal and external anal sphincters line the anal canal. The internal anal sphincter surrounds the upper 3/4 of the anal canal, and its lower extremity is the white line known as Hilton's line. In this picture, you can see that the internal anal sphincter encircle 3/4 of the anal canal and lies within the external anal sphincter. And at the lower extremity present the Hilton line. The white line or the Hilton line is the transition point between the internal anal sphincter and the subcutaneous part of the external anal sphincter. That the internal anal sphincter where it ends, there subcutaneous part of the external anal sphincter is present, and in between these two there is presence of the Hilton line. The internal anal sphincter is formed by the circular muscle coat of the rectum become thicker at this anorectal junction, thus forming the sphincter. Here you can see that the inner circular muscles of the rectum at the level of the anorectal junction, they become thick and they form internal anal sphincter. Now, internal anal sphincter is involuntary. Its function is dependent on the integrity of the rectoanal inhibitory reflex, which involves the relaxation of the internal anal sphincter in the presence of the rectal distension. It maintains a resting pressure in the absence of rectal distension. Thus, the internal anal sphincter's resting pressure is widely used as a direct measure of its functionality and is often assessed when evaluating a variety of pathologies. External anal sphincter surrounds the lower part of the anal canal, overlapping the internal anal sphincter, and is inserted into the skin at the lower end of the anal canal. The external anal sphincter can be divided into deep, superficial, and subcutaneous regions. Deep fibers of the external anal sphincter interdigitate with fibers of the puborectalis and with the muscles of the deep perineal pouch via the perineal body. As I have told you before, that you can see that there are deep part of the external anal sphincter, then there is superficial part of the external anal sphincter, and then there is the subcutaneous part of the external anal sphincter shown in this picture clearly, and their fibers interdigitate with the puborectalis, which is part of the levator ani muscle. The perineal body is a fibromuscular node between the urogenital region and the anal region, where the muscles of the two regions unite to form a functional unit. Fibers of levator ani also contribute to the perineal body. Now, the perineal body, it is a fibromuscular structure which is present between the genital opening and the anal opening. Now, the superficial fibers of the external anal sphincters are inserted to the coccyx and contribute fibers to the anococcygeal ligament, a body of fibrous and muscular tissue separating the anus from the coccyx. Now, here you can see the external anal sphincter muscles. They insert on the tip of the coccyx, and they are forming a fibromuscular structure called anococcygeal ligament. The subcutaneous part of the external sphincter is a thin horizontal band around the distal part of the anal canal. It lies below the internal anal sphincter with some fibers attaching to the anococcygeal ligament and the perineal body. This part of the sphincter does not have any bony attachment. Now, here you can see that the subcutaneous part of the external anal sphincter lies below the internal anal sphincter. Some of its fibers are attached to the perineal body and some of its fibers are attached to the anococcygeal ligament, but it has no direct bony attachment. Now, the external anal sphincter is under voluntary control. The external anal sphincter maintains its tone to keep the orifice of the anal canal closed and relaxes upon defecation, while the anorectal inhibitory reflex causes the internal anal sphincter to relax in the presence of rectal distension. The external anal sphincter works to keep stool in the anal canal until one is ready to defecate. So, external anal sphincter is under voluntary control. Now, when seen from internally, the upper part of the anal canal is lined by mucous membrane, which is thrown into longitudinal folds. These folds are termed as anal columns. The anal columns are characterized at their distal end by having anal valves and anal sinuses. Here you can see in this picture anal canals, and at the distal end present anal valves. The pectinate line is a visible zigzagging line formed from the inferior aspect of the longitudinal folds known as anal columns or anal valves. The pectinate lines demarcates the superior 2/3 of the anal canal from the inferior 1/3. Now you can see in this picture the pectinate line. Now the area between the pectinate line and the anal margin is called pectin. Blood supply. As the anal canal has two origins, so the blood supply of the two origins is different. Above the pectinate line, the anal canal is supplied by terminal branches of the superior rectal artery, a branch of inferior mesenteric artery. Below the pectinate line, the anal canal is served by the middle and inferior rectal arteries. The middle rectal artery is a branch of internal iliac artery, while the inferior rectal artery is a branch of internal pudendal artery that arises from the internal iliac artery. Now in this diagram you can see above the pectinate line is supplied by superior rectal artery, which is a branch of inferior mesenteric artery, and the inferior to the pectinate line is supplied by middle and inferior rectal arteries, which ultimately drain into the internal iliac artery. Now the venous drainage. The venous drainage of the anal canal superior to the pectinate line is to the superior rectal vein, which drains into the inferior mesenteric vein. These veins are part of the hepatic portal venous system, conveying oxygen poor but nutrient rich blood to the liver for processing. The venous drainage of the anal canal below the pectinate line is from the internal pudendal veins, which convey their content to the internal iliac veins. These veins are part of the systemic venous system that transports oxygen poor, nutrient poor blood to the heart. So the portocaval system is present above the pectinate line, not below. Now the anastomosis of the portal and systemic venous systems within the anorectal canal allow for potential collateral circulatory routes. In patients with portal hypertension, anorectal varices may be present. This is the diagram. Here you can see the above the pectinate line is drained by superior rectal vein, which is drained ultimately into the inferior mesenteric vein, and below the pectinate line is drained by middle rectal and inferior rectal veins, which drain into the internal pudendal vein and then into the internal iliac vein. Now the lymphatic drainage. Above the pectinate line, lymphatic fluid from this region is conveyed to the inferior mesenteric lymph nodes, and the lymphatic drainage below the pectinate line is primarily to the superficial inguinal lymph nodes. Here you can see above the pectinate line, lymphatic drainage is to the inferior mesenteric nodes, and you can see that and in this picture you can see that the lymphatic drainage below the pectinate or dentate line is to inguinal nodes. Nerve supply. Above the pectinate line, the anal canal receives autonomic innervation from the inferior hypogastric plexus. The parasympathetic innervation inhibits the tone of the internal anal sphincter and evokes a peristaltic contraction to allow defecation, while the sympathetic innervation works in opposition to and it maintains the tone of the internal anal sphincter and preserves continence. Given viscerosensory signal returned from this region, the superior aspect of the anal canal is more sensitive to stretch or distension. Now, below the pectinate line, the anal canal receives somatic innervation, which is derived from the branches of the pudendal nerve. As a result, the inferior aspect of the anal canal is highly sensitive to pain, temperature, and touch. This is a diagram you can see above the pectinate line. Innervation um, is from hypogastric nerves, and below is from pudendal nerve. Now, clinical relevance. This is obstetric anal sphincter injuries. Perineal tears during childbirth are classified into the following definitions depending upon the anatomy of the perineum and the anal region. In the first degree, injury to the perineal skin only. Here in the first degree, you can see only the perineal skin is torn. In second degree, injury to the perineal muscles but not involving the anal sphincter. Here you can see in second degree perineal muscles are also involved, but not the anal sphincters. They are intact. In third degree, injury involves the anal sphincters. Now they are again classified into 3A, 3B and 3C. In 3A, there is less than 50% of the external anal sphincter muscles torn, and 3B, more than 50% of the external anal sphincter torn, and 3C, when both the external anal sphincter and the internal anal sphincters is torn. Here you can see sphincters is involved in third degree. In fourth degree, damage to both external and internal anal sphincters and also the anal epithelium is involved. Here you can see in the 4th degree tear. Now, what is obstetric anal sphincter injury care bundle? This is I have taken from RCOG. During the antenatal period, discuss obstetric anal sphincter injury with women and what can be done to reduce the risk of it occurring during birth. Manual perineal protection while communicating with the woman to encourage a slow and guided birth. If clinically indicated, mediolateral episiotomy should be performed at an angle of 60 degrees from the midline at crowning. Systematic examination of the vagina and anorectum even if the perineum appears intact. This is important and you won't miss any injury. Now the question is, the anal canal, the upper half is lined with cuboidal epithelium. This is wrong because the upper 2/3 is lined by simple columnar epithelium. The lower half is lined with non-keratinized stratified squamous epithelium. This is true because lower 1/3 is lined by non-keratinized stratified squamous epithelium. The third option is the fibers of the ischio-coccygeus form part of the internal anal sphincter. This is false because the circular muscles of the rectum they become thick and form the internal anal sphincter. The dentate line lies at the border of the upper 1/3 and lower 2/3 of the anal canal. It is false because dentate line or pectinate line lies at the border of upper 2/3 and lower 1/3 of the anal canal. Hilton's lines indicates the junction between keratinized and non-keratinized stratified squamous epithelium. This is true. Thanks for watching. If you like my video, please subscribe to my channel and click the bell icon for more updates.